integral component of your report on auscultation. Once you have commented on the split, you proceed to comment on the intensity of A2 and P2. Look for any additional sounds, S3 or S4, any other additional sounds, and any murmur. Each one of these points we are going to emphasize and describe and clarify your doubts as to how is it that you elicit the finding. Before that, let's recall this diagram, which is from all textbooks of physiology that you have learned. What it shows, there are too many things in the picture, a very busy one, but you can see the LV pressure trace. There is an LA pressure trace superimposed on it. There are heart sounds superimposed on it. What is missing is only the ECG. Now, why do we show this? Imagine the beginning of the systole. The beginning of the systole is with the first heart sound. If you had an ECG there, you will find a QRS complex which will time with S1. It also times with the upstroke of the LV pressure trace. And when the LV pressure is beginning to rise with all valves closed, you refer to that phase as isometric contraction. At the end of isometric contraction, LV has generated enough pressure to open the aortic valve. You can all say the same thing with regard to the right heart and say the RV and the pulmonary valve. For convenience, I'm referring only to the left heart now. So the aortic valve opens. The moment the aortic valve has opened, the phase of rapid ejection followed by the phase of slow ejection will follow. And then at the end of the phase of slow ejection, or maybe a short period of diastasis, you get the second sound. When the second sound is inscribed, systole is over. So systole extends from S1 to S2. And after S2, what's happening to the pressure trace? See this blue part? LV pressure trace is rapidly dropping. LV pressure is rapidly dropping. Why? It is rapid relaxation. It merges with slow relaxation. This merging, rapid to slow relaxation transition, is an important auscultatory phase because it is here that a third sound will happen. Then the slow relaxation proceeds, the left atrium contracts, there is an LA pressure which is superimposed on this, and you're ready for the next first sound. So the first sound marks the beginning of the isometric contraction. It times with the QRS complex. The second sound marks the end of systole. This is followed by the rapid relaxation. When it changes from rapid to slow relaxation, the S3 is inscribed. Try to remember this picture and refer to this later. You will find this in all books. Now let's come back to our heart sounds. How are they caused? They're caused by the closure of the respective valves, the AV valves in the case of the first sound, and the semilunar valves in the case of the second sound. But it's not that the coaptation or the valve leaflets is actually causing the sound. It's more likely that the sudden deceleration of blood flow, which is occurring after valve closure, and this causes the surrounding cardiac structures and tissues, particularly the chordopapillary structures, to vibrate. And these vibrations are responsible for the first sound and the second sound. So yes, AV valve closure is related to it, but the actual generation of the sound is from the chordopapillary structures, the deceleration of blood, and maybe with a contribution from the heart muscle as well. So let's come to the first sound. The first sound is caused by the closure of mitral and tricuspid valve leaflets. The vibrations, what the vibrations do, we have just now discussed. Remember we said it times with the end of diastole, that's a QRS complex. And if you're timing it with the carotid upstroke, if you have a finger on the carotid pulse, the first sound is before the carotid pulse. It's a high pitched sound. Therefore, you will hear it better with the diaphragm. 80% of the intensity of the first sound is from the mitral component. Let's call it M1. and 20% is from T1. M1 is best heard over the apex beat, T1 over the tricuspid area. The interval between M1 and T1 is less than 20 milliseconds. You need at least 20 milliseconds for our ears to perceive two sounds as distinct. 30 makes it more comfortable, but something less than 20 you're going to hear as a single sound. That is why normally the first sound is a single event. But if M1 T1 gets separated by a wider interval, as would happen in complete right bundle branch block or with Epstein's anomaly, the first sound can be heard split. When you hear it split, it means that the T1 is audible in addition to M1. Therefore, you would hear the split in the tricuspid area. When you are looking at the first sound, we are obliged to look at the intensity of the first sound. So to understand the intensity of the first sound, you must think of the factors which would affect the intensity of the first sound. You can compare the mitral valve apparatus to a wooden door, and you are going to close the wooden door. You can generate a variable amount of noise by closing a door. You can slam it shut and generate a loud sound. You can slowly close it and generate a soft sound. Your door may be so bad and creaky that however you close it, the sound may be dull. All these similes would apply to the valve. The integrity of the valve apparatus. To speak of other factors influencing the first sound, the valve itself should be of good material, no fibrosis, no calcification. So the integrity of the valve apparatus. Where is the valve leaflets at the end of diastole? Where is your door when you're beginning to close it? Is it wide open? So when you close it, you have a louder sound. It's about to close. When you close it, you have a dull sound. So if the valve leaflets are far apart, as is the case with a heightened left atrial pressure as in mitral stenosis, you hear a loud sound. Same thing with a PR interval. If the PR interval is short, then the distance from the atrial contraction to the occurrence of the valve closure is very short, and the sound will be loud. Contrariwise with a long PR interval. The other factor, if everything else is okay, is the rate of rise of LV pressure. We speak of it as LV dP by dt. How fast is the pressure rising in the LV in the first sound, the door closure sound. Thereby, we imply that if the LV dP by dt is brisk, you hear a loud sound. If it is dull, as in viral myocarditis, you hear a dull sound. So these are some of the mechanisms how the intensity of the first sound is altered. So now let us actually translate this into clinical situations. The loud S1 could be due to mitral stenosis, tachycardia, short PR interval, high flow across the mitral valve as in a left to right shunt post tricuspid, or the LV-dP by dt. And a feeble S1 when there is an acute mitral regurgitation, the valve leaflets are close, near closed at the end of diastole, so that the systole brings only a minimal movement of the valve leaflets. Viral myocarditis, dP by dt is low. Same thing for dilate cardiomyopathy. Not pediatric, but in older age, acute myocardial infarction. Extracardiac causes like obesity, increasingly a problem in pediatrics. The first sound may vary in intensity from beat to beat. This happens in complete heart block. This is because the atrial contribution is varying in a beat to beat relationship. Or Wenke-Back AV block, the PR interval is changing. If you have frequent ectopics, ventricular ectopics, atrial ectopics, atrial fibrillation, all these can alter the intensity of the first heart sound. We refer to the split first sound. If the first sound is split, it means you are hearing the T1. And if it is the T1 that you are hearing it in the tricuspid area. Complete right bundle branch block, Epstein's anomaly, atrial septal defects sometimes. If you pace the left ventricle, when you pace the epicardium, in a small baby, if you're putting in a pacemaker, it is on the LV epicardium. When you pace the LV, It is like a right bundle branch block. It can be associated with a split first sound. Now the second heart sound can have a splitting. It does have a splitting, but the question is, when does it happen? When the baby is born, the baby has a single second sound. Towards the end of the first week, maybe day 5, day 6, like that, the split starts appearing. What do you mean by the split? When the baby is breathing in inspiration, the A2, P2 interval is widening. So if you keep your hand on the baby's tummy, even in an older child, don't ask the patient to take a deep breath. Just keep your hand on the child's tummy and you know whether you are in inspiration or expiration. When the baby or the child is breathing in, the split widens and it becomes audible. In expiration, it appears as a single sound because the A2 and P2 fuse. Why does the second sound split? There is an increased inspiratory venous return, and the right heart has to eject a larger volume in inspiration. So the RV ejection, even normally, is completed after the LV ejection. That is why P2 follows A2. In inspiration, it will follow even by a greater distance, thereby causing an audible split. So this is an increased inspiratory venous return. The other thing is the concept of the hangout interval. In the picture that we showed relating the heart sounds to the pressure tracings, we showed that the A2 corresponds with the pressure crossover between the LV and the aorta. When the aortic pressure when the LV pressure has dropped below the aortic diastolic pressure, the A2 is occurring. It is not so in the right side. The pressure crossover of course occurs, but the P2 doesn't instantly follow. The P2 follows after a certain interval. The interval or the time that the P2 takes to occur after the pressure has crossed over is called the hangout interval. You can say that the pulmonary valve is hanging out, not returning home. And this hangout interval is a feature of the pulmonary vascular resistance. The normal pulmonary vascular resistance is several times lower than the systemic vascular resistance. So the pulmonary vasculature with the low resistance is responsible for the longer hangout interval. This longer hangout interval and the inspiratory venous return, both these are responsible for the wide split. Now, how do you appreciate the split? It has to be appreciated in the pulmonary area because the normal P2 is audible only in the pulmonary area. The second sound that you hear elsewhere is all A2. Both A2 and P2 are high pitch sounds, so you will hear it better with the diaphragm. But the normal P2 is less intense than the A2. If P2 appears equal to A2 or is louder than the A2, then you say that the P2 is loud. So now we have explained how to hear the split, auscultate in the pulmonary area, listen in quiet breathing. In inspiration, look for the widening and audibility of two sounds. Then comment on the intensity of the sound. Relate P2 intensity to A2. If P2 is same or loud as A2, you call it loud. If it is palpable, you call it loud. The second sound that you hear anywhere else is the A2. So evaluating these two, you have to comment on the splitting and the terms that you would use: normal, wide, fixed, paradoxical, or single. You can't hear the split. And intensity, comment on the A2 and P2. So we said about the normal splitting, about the split widening inspiration, as the pulmonary valve with a longer hangout interval is handling the increased venous return. For reasons that you can imagine, split is better heard in the supine position because the venous return is maximal in the supine position. The split tends to fuse when the child stands up. So a wide split means that the split is wider in inspiration. It is heard in both supine and standing position. And In expiration, it still narrows down. Quite often, when you have a wide split and you have a doubt as to whether it is fixed or not, in an older child, if you can make the child stand up, you will find that the sound easily fuses in expiration, and then it is easy to say that it is a wide split with normal mobility. But when the split is wide, there are reasons for it. It may be because the P2 is further delayed. P2 is already delayed in relation to A2. It may be further delayed, or the A2 is occurring too early. Either way, you can have a width of the split. So if you are looking at a delayed P2, you can think of mechanical reasons doing this, and you can think of electrical reasons doing it. Mechanical reasons, you can think of valvar pulmonary stenosis, Epstein's anomaly, ASD. In all this, the ejection is prolonged and the P2 is inscribed later. You can have electrical reasons doing it, there being nothing structurally wrong with the heart. And the prototype electrical reason is a right bundle branch block. The RV excitation starts later. The equivalent of that is a WPW syndrome with the accessory pathway on the left side. It is the LV which is pre-excited, so RV is relatively later. If you pace the left ventricle, the same thing happens. If there is an ectopic beat, a ventricular ectopic beat arising from the left ventricle, the same thing happens. So a wide split can be due to a delayed P2 in all these reasons. It can also be due to an early A2 if you have an extra smart LV which is trying to finish its contraction earlier. When would the LV do that? If you give the LV a diastolic stretch, as with a mild or moderate mitral regurgitation or a small moderate VSD. Then you have an optimal diastolic stretch for the LV. LV contracts vigorously, completes its pumping earlier. So the A2 has occurred earlier, P2 is remaining the same place, and you have a wide split. So the wide split may be due to a delayed P2. We said electrical and mechanical reasons for that. It may be due to an early A2. Mitral regurgitation VST are the classic reasons by which this can occur. Now we come to the fixed splitting. By fixed splitting, we mean the split is audible in both phases of respiration without any change. In inspiration, it is there. In expiration, it is there. You make the kid stand up, it is there in both inspiration and expiration. This is fixed split. Now, why does a fixed split occur? The characteristic condition with which fixed split is associated is atrial septal defect. In atrial septal defect, the right ventricle receives two sources of blood flow. One is of course from the SVC and IVC, and with inspiration this tends to increase. The other is the left to right shunt across the atrial septal defect. Now the left to right shunt across the atrial septal defect is more in expiration when the LA pressure tends to go up. The venous return is more in inspiration. These two vary reciprocally. In other words, the inspiratory increase in the right heart filling is offset by the reduction of the left to right shunt in inspiration. Contrariwise, the expiratory decline in the systemic venous return is balanced by the increase in the left to right shunt across the ASD. The net result, the RV gets the same input in both inspiration and expiration. So the extent to which P2 is delayed, mind you, because there is a greater volume for sure. And the extent to which the P2 is delayed remains the same in inspiration and expiration. Hence your fixed split. So this explains it for ASD. But if you have a condition where the RV is too weak or too limited in its expansion ability, it will also have a fixed split. If you have a severe myocarditis, or if you have a constrictive pericarditis, in myocarditis, the dysfunctioning RV, whatever be the input, it can't increase its output. In constrictive pericarditis, the RV has, the moment RV tries to dilate in inspiration, the constricted pericardium says no. So the extent to which there can be any variation in the RV input is limited, and therefore the second sound can have a fixed split. So severe RV dysfunction and constrictive pericarditis would also be causes for a fixed split. But in these instances, the fixed split is not as wide as you would get in ASD. Now you can also have a paradoxical split. You say that the split is paradoxical when the split is wider in expiration. You expect the split to be wider in inspiration, but instead, if the split is wider in expiration, it is a paradoxical split. For this, the A2 has to occur after P2. Normally A2 occurs earlier than P2. In a paradoxical split, A2 occurs after P2 and you hear it in expiration. This happens when the either there is an electrical cause or there is a mechanical cause causing the LV to eject slowly or delayed. Left bundle branch block is the prototype lesion. You can get left bundle branch block like physiology if you are pacing the right ventricle. A normal endocardial pacemaker is located, the lead is located in the RV. If you have a pre-excitation, Epstein, a WPW with a accessory pathway on the right side, you have a similar situation. If you have an ectopic beat arising out of the RV, during that ectopic beat, you can get a paradoxical split. So these are the electrical reasons by which a paradoxical split occurs. Mechanical reasons, if you have severe aortic stenosis, LV dysfunction, then especially hypertension with LV dysfunction, you can get a paradoxical split. In the second sound, you assess the split, and once you have assessed the split, you move on and comment on the intensity of A2 and P2. The commonest cause for a loud P2 is pulmonary hypertension. But with normal PA pressures, the P2 can be loud if the pulmonary artery is dilated. This happens in ASD. You have a large pulmonary artery. There is the condition called idiopathic dilatation of the pulmonary artery, which may occur in normal children or in presence of Marfan syndrome. The dilated pulmonary artery causes the vibrations to come closer to your chest wall and to your stethoscope. So that's a cause for a loud P2. And if the chest wall is thin, of course, the P2 may appear loud. A feeble P2 or an absent P2, severe valva PS, you tend to have a feeble P2. In a pulmonary atresia, you have an absent P2. In tetralogy, your P2 is very dull. In tetralogy, it is dull because think of the anatomy of tetralogy. You have the VSD, you have the infundibular stenosis. Below the pulmonary valve, you have the infundibulum, whose pressure is low. Normally, the pressure in the infundibulum is same as the pressure in the RV cavity. But in presence of a stenosed infundibulum, the pressure in the below the pulmonary valve is low. There is a gradient between the infundibulum and the RV. Now in diastole, RV is beginning to relax. Ordinarily, the infundibulum have relaxed in sync with the RV cavity. But here, there is a the delayed and hesitant closure of the pulmonary valve because the infundibulum relaxes slowly and the pressure there is lower. So the delayed and hesitant closure of the pulmonary valve because of infundibular stenosis is responsible for the dull P2. Add to it the fact that the pulmonary valve is small, it is covered by a dextropost aorta. The aorta is dilated and it tends to cover the pulmonary route in tetralogy. So these are the reasons why the second sound is feeble or absent even in tetralogy fellow. Now when you look at intensity of A2, you can have a loud A2 in hypertension if the aorta is dilated as in tetralogy, and if the aortic valve is unusually close to the chest wall, again in tetralogy or in transposition, particularly corrected transposition, the vessels are side by side, the aorta is left and anterior, it occupies a position similar to that the pulmonary artery, and you can even palpate a loud A2 in the pulmonary area. A feeble A2 may denote a calcific aortic stenosis in the adult. Severe aortic regurgitation or hypotension may be associated with a feeble A2 in the child. Second sound can be single. Now when the second sound is single, it means A2 and P2 are fused or one of them is absent. You know, think of the conditions where they are fused. An Eisenmenger VSD. Both the vascular resistances are similar, both systemic and pulmonary vascular resistances are similar, and the closure of A2 and P2 occur simultaneously. Even in a large VSD, the pulmonary vascular resistance is much higher and the P2 is only marginally delayed. You quite often hear a normal, a single second sound in a VSD with a large VSD in a 3-month or 4-month-old baby also. Now, an absent P2 will of course occur in a pulmonary atresia. There is this condition called tetralogy absent pulmonary valve. These are instances where pulmonary valve is absent or following tetralogy repair, quite often there is no pulmonary valve. The abnormal position of the pulmonary artery as in a transposition and aortic second sound being absent, the neonate is hypoplastic left heart aortic atresia. In the adult, calcific aortic stenosis. Or in the case of truncus arteriosus, you have only one valve, so you can hear only one sound. I earlier referred to the second sound in corrected transposition, the aorta being left and anterior, underlying the pulmonary area, and in CTGA, therefore, you can have a loud A2 in the pulmonary area. After S1 and S2, we are moving to S3. S3 is a low frequency sound, sorry for that incomplete spelling, due to the shudder of the ventricular myocardium. And when does the ventricular myocardium shudder? As it changes from the rapid elongation or the rapid relaxation to the slow elongation in diastole. At this time, the chordopapillary structures and even the chest wall would have a shudder which is responsible for generating the third sound. It's best heard with the bell, not the diaphragm. It may be palpable. It's a mid-diastolic event. It occurs about 90 to 150 milliseconds from A2 if the heart rate is normal. And the irony of the third sound is that a third sound we hail as a sign of a normal heart in a child, and we also hail it as the first marker of a dysfunctioning left ventricle in the failing ventricle. This would seem paradoxical and would demand an explanation. This is because remember what generates the sound is the transition from the rapid elongation to the slow elongation of the ventricle. This is to begin with an intrinsic property of the ventricular myocardium. You have a very supple myocardium in a 3-year-old or a 5-year-old child. So the transition from the rapid elongation to the slow elongation is an abrupt one which can generate the vibrations that cause the third sound. That is a feature of the physiological third sound in the child. This property is lost as the child ages. In adulthood, the ventricular myocardium doesn't have this suppleness to generate that sound. So if you take away that property of the myocardium itself, then what governs the occurrence and the intensity of the third sound is the left atrial pressure. If you have a high left atrial pressure, under the gaze of the high left atrial pressure, the transition from the rapid filling to the slow filling would occur faster, more abruptly, and this is what happens in left ventricular failure. So there's a high atrial mean pressure with normal AV valve orifice. That is what you mean by when the left ventricle is failing, as in a cardiomyopathy, the left ventricular end diastolic pressure is elevated, the LA mean pressure is elevated, and this is associated with the third sound. Now, none of these may be there, but there may be too much flow through the mitral valve. If there is too much flow through the mitral valve, this transition from rapid elongation to the slow elongation would still be marked. And that happens in mitral regurgitation in a PDA or in a VSD. You are quite often asked, how do you distinguish a physiological third sound from a pathological third sound? You could start by thinking that it's an older child and young adult who would have a physiological third sound, while a pathological third sound would occur at any age. A physiological third sound is a myocardial property, while a pathological third sound is related to a high filling pressure. A physiological third sound has a normal heart rate. A pathological third sound usually will have a tachycardia because there is a heart failure. A physiological heart will never have a fourth heart sound. A fourth heart sound means the ventricular stiffness is more. So a pathological third sound may be associated with a fourth heart sound. A physiological third sound will disappear with exercise. A pathological third sound will be augmented by exercise because exercise worsens heart failure. A physiological third sound, the heart size is normal, but pathological third sound denotes cardiac failure and therefore it is associated with a cardiomegaly. And some of the physiological numbers that go with a pathological third sound, it happens when the LVEDP is at least 15 millimeters of mercury, usually more. LVEDP denotes heart failure. So if you check the BNP, it is more. In the echo, it goes with a reduced ejection fraction. In the chest X-ray, the high left atrial pressure would cast upper lobe vessels. It would cause cardiomegaly. In the ECG, it will cause a left atrial enlargement. Now the fourth heart sound. It's a low intensity sound due to the shudder of the ventricular myocardium caused by the late diastolic augmentation of LV filling from the atrial contraction. It is always pathological and it means the ventricle has become too stiff. You hear it with the bell of the stethoscope. So an LVS4 is heard with hypertension, aortic stenosis, coarctation, hypertrophic cardiomyopathy. An RVS4 with conditions that elevate the RV pressure, either pulmonary hypertension or pulmonary stenosis. How do you hear it? It will sound like a split S1 because you're hearing two sounds in relation to the timing of S1. And when you're hearing that, remember, if it is a split S1, it is an M1 T1. You have to hear the T1. You will hear it better in the tricuspid area. If it is a left-sided S4, which is much more frequent, you will hear it over the apex beat. So it is over the apex beat that you hear the S4, S1. Later, I'll be referring to an S1 ejection click. An ejection click is a sharper and a louder sound and it has no respiratory variation over the apex beat. So a left-sided S4 is better heard in expiration. A right-sided S4 is better heard in inspiration. In complete heart block, the atrial contractions are unrelated to ventricular contractions. And the regular atrial contractions may be audible as dull, regular sounds, and they are called the half sounds of Stokes. Remember Stokes-Adams attacks? So these are Stokes half sounds. The opening snap is a high-pitched diastolic sound which is caused by the sudden opening of mitral valve in mitral stenosis. The mitral valve domes because it's not free to open. As it reaches the maximum excursion of its opening, it generates a snap. The A2 to OS interval is short with severity of mitral stenosis, which means the more severe the mitral stenosis, the earlier the opening snap and the longer the mid-diastolic murmur. Is best heard with the diaphragm of the stethoscope over the apex beat in the left lateral position. Now after sounds, we speak of clicks. A click, an ejection click, there is a phasic ejection click and a constant ejection click. You also have a non-ejection click of mitral valve collapse. I will not be discussing that because that's a topic in itself. The phasic ejection click occurs in valve RPS. Remember in valve RPS, you have a doming pulmonary valve. In systole, as the valve tries to open, it's unable to open freely. Instead, it domes with the pressure building up on the ventricular side of the valve. And the abrupt cessation of the doming movement causes the click. And interestingly, the pulmonary ejection click is louder in expiration. Please note the pulmonary ejection click of valve PS is the only right heart event. Repeat, the only right heart event which is louder in expiration. Everything else is louder in inspiration. Why so? The RV has to handle the inspiratory venous return. So given a larger inspiratory venous return, the better filled RV tries to push open the pulmonary valve, and at the end diastole, the pulmonary valve is closer to an open position. As against expiration, when the RV filling is the least and the pulmonary valve is at the beginning of its opening. So the range of excursion is more in expiration, less in inspiration. With a wider range of excursion, you hear a louder, more prominent phasic ejection click. It's called phasic because it varies between inspiration and expiration. And again, the interval from the first sound to the click, the more severe the stenosis, the click becomes closer to the first sound, so close that it fuses with the first sound. Therefore, in severe valve PS, when you auscultate over the pulmonary area, what you hear is what looks like a loud first sound. Remember, the first sound has no business to be loud in pulmonary area selectively. So if you hear the loud first sound in pulmonary area alone, check whether it is heard in inspiration or expiration. You will realize that it is in expiration that the first sound appears to be loud, and this is because a click is fusing with the first sound. In severe PAH, you may get a click, and that is a constant click because that does not obey these rules. That is a vascular click, and that's a constant click. Sorry. Excuse me. A constant ejection click is a feature of a bicuspid aortic valve. The bicuspid aortic valve also domes in systole. Why is the bicuspid aortic valve click constant where the uh, pulmonary stenosis click is phasic? You are speaking of the inspiratory filling of the ventricle influencing the position of the valve. It is all right when the diastolic pressure in the artery is 5 or 10, as is the case of pulmonary artery. But if the diastolic pressure is 80, that's a different ball game. So the LV pressure also changes between inspiration and expiration, but the diastolic pressure of the aorta being high, it does not allow the inspiratory or expiratory changes in the LV volume to influence the position of the bicuspid aortic valve. And therefore, it is a constant click. It is best heard over the apex beat and the aortic area. You can distinguish it from S1, S4 and M1, T1 in the ways that we said. It's a loud, sharp sound with no respiratory variation. What are the other sounds that can occur? You can have a vascular click from a dilated aorta, very common in tetralogy where ascending aorta is dilated. In hypertension also you may get it. And a dilated pulmonary artery in Eisenmenger syndrome, pulmonary arterial hypertension, idiopathic dilatation of the pulmonary artery. All these conditions may be associated with a loud sound. You can hear multiple clicks in PDA, a long PDA. There are eddy sounds coming from the bends in the long PDA. And you can have a non-ejection click in mitral valve prolapse. Basically, what we mean is it is not related to LV ejection. It occurs later in systole, and it is because the chordae are too redundant or the valve leaflets are prolapsing. And the prolapse, when it reaches the limit, that is generating a click. A small LV will generate a loud, an earlier click. So when the person is standing up, relative to lying down, it's a small LV, and therefore you have an earlier click. As I said, I will not be discussing in detail a non-ejection click. Another sound that you hear is a pericardial rub, very common in a viral pericarditis, in rheumatic carditis, or in the post-hoc child on the day 2, day 3 after surgery. The trauma to the pericardium always causes a pericardial rub. It's a triphasic sound, it's a superficial sound, it's a leathery sound, a peculiar rough quality. Now from sounds we need to move to murmurs. A murmur is generated by turbulent flow across something. So you have to describe the timing of the murmur. Is it systolic, diastolic? In systole, where exactly? The grade of the murmur, grading we will discuss. The pitch of the murmur, the frequency of the sounds. the character of the murmur. Does it have a respiratory variation? Does it have any conduction? So a systolic murmur can be pansystolic when it extends from S1 to S2, like ventricular septal defect small or mitral regurgitation. It can be early systolic when it begins with S1 but ends before S2. Happens with a large VSD because in the later part of systole the pressures have equilibrated. Or in a small muscular VSD, the VSD is squeezed shut in the later part of systole. It's also heard in acute MR because in later part of systole, the LA pressure is high and it prevents any flow from LV to LA. It's ejection systolic when there is an interval after the A2 for the sound to occur or an interval after the P2 also. And it ends before, the ejection systolic on the left side occurs after S1, ends before A2. On the right side, it occurs after S1, occurs before P2. On both sides, there is a short gap. Late systolic, it begins late in systole and ends with S2, as is the feature of mitral valve collapse, mitral regurgitation. So you have to say it is systolic and say in which part of systole. Try to use one of these words. A diastolic murmur also needs to be similarly described. An early diastolic murmur will begin with A2 or P2 in aortic regurgitation or the hypertensive PR. It's always called the Graham-Steele murmur. It's an early diastolic blowing murmur. A delayed diastolic sound and in an absent pulmonary valve or a tautology post-repair, the PR doesn't begin with the P2. There is an interval and it's a medium pitch. It's a delayed diastolic murmur. A typical mid-diastolic murmur is the flow murmurs of mitral regurgitation or PDA or VSD or the mitral stenotic murmur. The pre-systolic murmur in the mitral stenosis murmur is a mid-diastolic murmur with a pre-systolic accentuation. The Austin-Flynn murmur is also a pre-systolic murmur. What is the Austin-Flynn murmur? In severe aortic regurgitation, there is a pre-systolic murmur with a normal mitral valve. Why does it happen? One, the dual filling of the LV, the AR flow as well as the normal diastolic flow, causes the anterior mitral leaflet to float up so that there is a relative mitral stenosis causing a flow in late diastole, a flow rumble in late diastole. Also, this anterior mitral leaflet is getting hit by the aortic regurgitation and vibrating or fluttering. Both these are responsible for the Austin-Flynn murmur. A continuous murmur, typically of a PDA or a collateral, it begins in systole and runs across the A2. You hear it in a PDA classically. It was Levine and Harvey who originally graded murmurs. They graded only systolic murmurs, but in current parlance, both systolic and diastolic are used. We use an American Heart Association classification for this. And while systolic murmurs are graded 1 to 6, diastolic murmurs are graded 1 to 4. So the grade 1 is heard on intense auscultation. Grade 2 is more readily audible. Grade 3 is still louder but no thrill. Grade 4 has a thrill. Grade 5 is louder and it is with a thrill. Grade 6, even with the stethoscope partially removed, you can hear it. We speak of the pitch and character of the murmur. A low pitch murmur, we are speaking of 25 to 125 cycles. Mitral stenosis is the example. It's a rather rough. A medium pitch murmur is like 125 to 300. This is the high-pitched innocent murmur or the innocent murmur of which you hear in many children. And a still higher pitch, more than 300 cycles, the early diastolic murmur of aortic regurgitation or the blowing mitral regurgitation murmur. When their character can be compared with something, you use that term, a blowing murmur of aortic regurgitation, a musical murmur of caudal rupture. Musical murmur means there is a mixed frequency. A machinery murmur of PDA, a honking murmur of mitral valve collapse, mitral regurgitation. So these are some of the characters that we speak of. And This picture illustrates some of the murmurs that you hear. Look at the first one, which is the normal first sound, second sound, the third sound, which is a mid-diastolic sound, and the S4, which is a pre-systolic sound. Here is an ejection systolic murmur, which begins a short interval after the first sound, peaks in mid-systole, and then wanes towards the end of systole, and there is a gap. Whereas a mitral regurgitation is a pan-systolic murmur. An aortic regurgitation is a long, early diastolic murmur. A mitral stenosis is a mid-diastolic murmur with a pre-systolic accentuation. And a continuous murmur is a harsh murmur that is peaking towards the second sound. Respiratory variation, you know that the right-sided murmurs increase with inspiration and the left-sided murmurs increase with expiration. And the site of maximum intensity, apex, mitral regurgitation, aortic stenosis, and mitral stenosis. In the aortic area, an aortic stenosis or an aortic flow murmur of AR. In the pulmonary area, the pulmonary stenosis murmur, ductus, or pulmonary regurgitation. Tricuspid area, tricuspid regurgitation or VSD. Over the back, coarctation, peripheral pulmonary artery stenosis, or pulmonary AV fistula. You use the word conduction when there is a selective propagation of a murmur with same or greater intensity. Example, aortic stenosis to carotids, a mitral regurgitation to axilla and back, a rheumatic mitral regurgitation. Innocent murmurs are very common in children. The vibratory Still's murmur, the venous hum from jugulars and brachiocephalic veins, the pulmonary systolic murmur from a thin chest wall and straight back, and the peripheral pulmonic murmur. In a neonate, the pulmonary arterial orifices are smaller relative to the main pulmonary artery, and this causes a murmur. You use the word bruit when you can't time it with systole and diastole because there are no heart sounds. So when you're hearing it over a vessel, you use the word bruit. You speak of a carotid bruit or an aortic bruit of coarctation or a femoral bruit. If you look at some of the murmurs in common conditions, in a VSD, a small VSD produces a harsh pansystolic murmur at the lower left sternal border, S3 and MDM over the apex beat. In a large VSD in an infant, it's an early systolic soft murmur. With a small muscular VSD, it's an early systolic murmur because the VSD is squeezed shut in later systole. In a PDA, the typical training tunnel or the machinery murmur is heard with a moderate size PDA in a slightly older child. It peaks towards the second sound, multiple clicks from the infoldings of a long ductus. You can hear an S3 and an MDM over the apex beat. A large PDA in an infant may be absolutely silent, or you may hear a systolic murmur with an apical MDM. A small PDA would also cause a continuous murmur, but you have a little more difficulty in hearing it. A tiny PDA is silent, and we say that a silent small PDA does not require closure. If you think of valva PS, it's a harsh ejection systolic murmur in the pulmonary area. It is preceded by the phasic ejection click, and the earlier the click, the longer the murmur, the more severe the PS. And in valvar AS, there's a harsh ejection systolic murmur in aortic area and apex, preceded by constant click. The earlier the click, the longer the murmur, the more severe the aortic stenosis. Tetralogy of fellow with a pulmonary stenosis has an ejection systolic murmur in the pulmonary area and the third space. It is because of turbulent flow across an obstructed RVOT. So if you have a long murmur in a tetralogy, it means a milder stenosis. In a spell, this will disappear because the infundibulum is shut during spell. And the flow across the VSD never produces a murmur because it's a large VSD. Tetralogy pulmonary atresia will not have any murmur except the murmur caused by collaterals that is usually in the back. Just a reference to the word dynamic auscultation. This is because you are using a maneuver or an inspiration to augment the features by increasing the flow. In inspiration, the right sided events increase unless it is a phasic ejection click, and expiration would increase a left sided event. Standing would decrease venous return, and that will cause a mitral valve prolapse click to occur early. Squatting in an older child It increases the afterload. It increases the venous return. You have a larger LV. It will delay the click of a mitral valve collapse. Valsalva maneuver you seldom employ in children. I will not refer to it. I can either stop here and take your questions, or I can show you one case to see how do you analyze history and the clinical findings to reach a diagnosis. Your call. You have 10 minutes. I think I'll take you through this case. There's a message here. Think of this baby. This is a 3-month-old girl, second by order of birth, born of non-consanguineous marriage. She's brought to you with complaints of dyspnea since early neonatal period, increasing in severity since the last 1 week. It worsens with feeds and it worsens with crying, and it is present even at rest. And she has progressive cyanosis since early neonatal period. The child is only 3 months now. There are no spells, no history of any failure to thrive. There is some forehead sweating, no convulsions, no wheezing, no respiratory infection. The birth history, there's nothing great. The birth weight was 2.25 kg. Baby had cried immediately after birth and had a normal neonatal period. There's no congenital heart disease in the family. The elder sibling is fine, normal immunization. When you have a history like this, before you start examining the child, you know that baby has left heart failure and the baby has cyanosis. So if this history had come without cyanosis, you would have thought about a large left to right shunt. But with cyanosis, you think of a congenital cyanotic heart disease with increased pulmonary blood flow, typical prototype being a TGA VSD. With that uh, bias in mind, you look at the child. It's a sick looking child. Respiratory rate is 80. There is some respiratory distress. You find retractions. There is uniform cyanosis and your SpO2 is 40%. The child has a little dysmorphic face. Anthropometry shows a weight of 4.5 kg, length of 60 centimeters and a head circumference of 37. Pulse is 180 per minute, regular, low volume. Peripheral pulses are normal, no radiofemoral delay. Blood pressure is 60/30. There's a prolongation of the capillary filling time. And CVS shows an apex beat in the left fifth space outside the midclavicular line, forceful. No parasternal heave. S1 is normal. S2 is single. There is a long early systolic murmur, grade 3/6 in the left upper sternal border. Respiratory system is fine. Liver is mildly enlarged. The ECG shows a normal sinus rhythm with a left axis deviation and LVH. The chest X-ray shows a narrow pedicle and an increased pulmonary blood flow. So you have reason to think now that you are dealing with a cyanotic congenital heart disease with increased pulmonary blood flow, and the ECG with a left axis deviation suggests tricuspid atresia. Therefore, in this baby, you are able to reach a diagnosis that this is a cyanotic congenital heart disease with increased pulmonary blood flow, and it is very likely tricuspid atresia with increased pulmonary blood flow. So what I have shown in this case is what I would expect from you when you are writing a case sheet for the students. In the history, there is a point in each of the words that you have noted, and you need to draw a conclusion from that. That history gives you a bias when you're examining the child, and also gives you further means of fine-tuning your diagnosis when you're looking at the X-ray and the ECG. I'll conclude with that and take any questions. We have 5 minutes. I can take any question. You can either send it as a chat message, or you can actually ask the question. Amrita?
Doctors, if you have any questions, please ask.
After all, we have discussed things that bothers you in your day-to-day clinical examination. So I would expect you to have questions.
Sir, I said you have one question.
Please shoot.
Good morning, sir. I'm Dr. Mukul from SIT Hospital. Can you hear me?
Yeah. Please go ahead.
Sir, some of the PDs are having murmurs in the left parasternal area. So, sir, what is the reason for that?
I didn't get it. Who has murmur in the
PDA,
parasternal area?
PDA,
PDA in the
PD.
fifth. PDA in
The
the fifth space.
parasternal area rather than the pulmonary area.
The typical murmur of PDA is actually just below the clavicle. It's not even in the pulmonary area. The systolic murmur of PDA may be heard more widely, but the continuous murmur is confined to the region below the clavicle or the pulmonary area. Like in the left fourth space, you will never hear a continuous murmur from a PDA. In fact, if you have a continuous murmur in the third or fourth space, your diagnosis is very different. Do you get me? The
Okay.
systolic murmur of PDA may be heard lower down the left sternal border. The continuous murmur of PDA is confined to the pulmonary area and even better, below the left clavicle. If you hear a continuous murmur in the fourth space, your diagnosis is different. Got it?
Okay, sir. Thank you.
Any other question?
Hello, sir. Hello, sir.
Any other questions?
Hello, sir. Sir. Sir.
Yes, Jadul, we can hear you. Please go ahead with your question.
Sir. I have a question, sir. Sir, can you hear, sir?
Faintly try. I'll try hearing. Just make your question anyway. I
Hello,
can
sir.
faintly
I
hear.
have a question, sir.
Yeah, please go ahead.
Can you hear? Can
Yeah,
you hear, sir?
yeah. Go ahead.
Sir, you shown the final case in the history. I said there is a feature of dysmorphic facies.
Yes.
Sir, is in the final diagnosis any syndromic diagnosis is there?
No, actually, this baby turned out to have a 22q11 deletion.
Okay, sir.
So the quite often, and this baby had a tricuspid atresia with a TGA.
Okay, sir.
In tricuspid atresia, when there is an increased pulmonary blood flow, it's a sort of standard DM teaching that if you have a tricuspid atresia with an increased pulmonary blood flow, think of TGA tricuspid atresia. So this baby happened to have a 22q11 deletion, which is to say that the dysmorphism was attributable to that.
Okay, sir. Okay. Thank you, sir.
I'm glad that you picked it up.
Okay, sir. Okay. Thank you.
Anything else?
Yeah.
Otherwise, we should wind up.
Any more questions? Sir, I think we can wind up, sir.
Okay, Amrita. Thank you.
Okay.